the location set. And so if you are here to see a day in the life of a stewardship champion, you are in the right place. If you're not, I'd suggest you stay because I think it looks like a really great presentation. My name is Kelly Donnelly. I am a communicable disease program specialist for the Lake County Health Department. And for those of you who are not from this area, we are the furthest northeast county in the state of Illinois. So we're bordered on the east by Lake Michigan and the north by Wisconsin. So we're really easy to find on a map. It is my pleasure to introduce the presenter here. Dr. Stephen Salisbury graduated from St. Louis College of Pharmacy with a PharmD degree. He worked as a pharmacist in the hospital setting for 7 years and pharmacy manager at Taylorville Memorial Hospital for 2 years. All 7 years were in a 25-bed critical access hospital. Stephen has led the Taylorville Memorial Hospital antibiotic stewardship program for 3 years. Stephen completed an antimicrobial stewardship certificate program through the Society of Infectious Disease Pharmacists. Several projects completed during his overseeing the stewardship program include SSTI power plant, pneumonia power plant update, antibiotic restriction policy update, NHSN reporting, pneumonia power plant compliance review, and pneumonia days of therapy reduction project. He could probably get very little sleep at night, correct? So it's my pleasure to introduce Dr. Salisbury.
All right, thank you. All right, so I have no conflicts of interest to disclose. I just wanted to start today with first defining what a stewardship champion is. How I'm choosing to define that is any staff member who leads the effort to implement and maintain antimicrobial stewardship activities. So I would think common answers would be infection control, nurse, pharmacist, physician, or other. So if you don't mind, I put out QR codes. If you can answer that question, I'd appreciate it. You have 13 responses so far. Can the back hear me okay? I need to speak into, okay. So it looks like pharmacy is the pharmacy manager is the overwhelming number one pick so far. Okay, thank you. That's the case at Taylorville Memorial Hospital as well. It's the pharmacy manager that oversees the program. So just to give you a little bit of background about Taylorville, we are comprised of a 5-hospital system. We serve patients over 40 counties. At Taylorville, we are a 25-bed critical access hospital. We have a 9-bed emergency department, outpatient infusion services, a surgical department, and we focus heavily on the swing bed program. So for those of you that aren't familiar with swing bed program, how I kind of define it to people that are hearing about it for the first time is patients that are not sick enough to stay in your larger hospitals, but they're not quite yet ready to go home yet. So they usually have some kind of skilled need. IV antibiotics is a common one that we see patients for, physical therapy, occupational therapy, those would be other skilled needs. We currently use CPSI, it's also known as Evident or TruBridge for our electronic health record. For those of you that work in a hospital, anybody ever worked with CPSI or, okay, a couple. Yeah, so it's, any hands of anybody that loves it or that loved it or they're glad that they're on something? Yeah, everyone's just kind of looking at me like, are you crazy? It's a little archaic, but, it's what we have. And then, so we use that throughout our whole hospital. And then in our emergency department, it gets fun because we use a different electronic health record called T-System. So I don't know if you've ever had the pleasure of working with 2 different electronic health records in one facility. clinical support, we have DoseMeRx and Theradoc, and we have system antibiotic support, which looks like, and how that looks like is we have monthly agenda and prep meetings, and we have a system meeting every other month, and then occasionally we have ad hoc meetings as well. So the objectives today are, I'm going to take you through the progression of time in our rural community hospital of our stewardship program. We're going to explain the importance of monitoring, describe some techniques to gain support for stewardship, and recognize some stewardship related references. All right, so let me change out of here. I'm going to go back into poll everywhere. So this question should be active now. And the question is, current state, does your antibiotic stewardship program meet the CDC? So it looks like about half and half, and that's pretty good. I would say that TMH does finally meet all the core elements. We just achieved that a couple years ago, even though we started the program back in 2015. Got one more question. Which CDC core element is the greatest opportunity in your facility? Sorry. So really all over the board. Give it a few more seconds, see if anybody else. Looks like action is leading the way with 43% and education with 21. So that's 2/3 of the room for action and education. So we'll touch a little bit on both of those in this presentation. All right. So our stewardship program began in 2015, and I just want to kind of go back in time and talk about what was going on at TMH then. So at that point, Taylorville had only 4 physicians that were seeing our acute care population. Those 4 physicians could come in at any time of day, and they were all primary care physicians. We also only had at that time only 1 pharmacist that was in the pharmacy during pharmacy hours because we are such a small facility. We don't have 24/7 pharmacists on site. Prior to the antibiotic stewardship program, pharmacists would do interventions, and they would document these in CPSI, and then we would present those to the PNT committee. So to gain hospital leadership, a formal presentation and a formal program was put together, and we had 2 goals initially. The first goal was pretty simple: to get the right antibiotic to the right patient at the right time with the right dose and frequency. The second was, like a lot of initiatives, we can save some money. IV is more expensive than PO, so those were the 2 things that were originally we focused on. How we were able to achieve some action and some accountability is a vancomycin dosing protocol was created. And then we tracked the performance of that protocol. A renal dose adjustment protocol was updated. So we had a renal dose adjustment for other medications. And we went through all the formulary, and any item or any medication that was on formulary that had an FDA approved renal dose adjustment was added to the dosing protocol. So pharmacists were able to adjust antibiotics based on renal function. And then finally, they tracked several of our protocols. So we had a CAP, an HCAP, and a sepsis protocol. and we started to track the compliance with those. So I don't know if I've seen a few confused looks in the crowd, and I don't know if that's just because we're so small and you're from larger institutions, but I just wanted to, I'm hopeful that's why they were, some of them are looking confused. Um, but to gain expertise, we don't have an infectious disease physician. We don't have an infectious disease pharmacist trained. It's very rare in a critical access hospital that you're going to find a board certified pharmacist at all. And then if you're a board certified infectious disease pharmacist, you're a unicorn. So to gain this expertise, we the pharmacy manager enrolled himself and the staff pharmacist into SIDP, Society of Infectious Disease Pharmacists Antimicrobial Program. It has 3 phases. The first is a self-taught continuing ed, go at your own pace. The second is live webinars, and the third is you have to do a project. And for the amount of money that this program costs and the amount of education that you're able to obtain, it is well worth the purchase. I have gone through the education, and I currently have a staff pharmacist going through it. So how did we take action this new stewardship program? Like I mentioned, we're only a 25-bed hospital. It's the pharmacist's responsibility at TMH to know when patients are admitted to our acute care floor. When a patient is admitted and they're on IV antibiotics, we would grab this form and we would put it on our clipboard and we would start filling it out. I'm going to just go through a few of the things that we always made sure that had to be done. The first was the diagnosis. So if a patient was getting admitted with, pneumonia or UTI, we made sure to put that in there. And then that helped us ask the question, are these really the right antibiotics to treat this disease state? Next, we would write down all the IV antibiotics that the patient was on throughout the entirety of this form being filled out. So if they, stopped on day 1, we would still fill it out and then usually try to explain why that happened. We built a 48 to 72 hour timeout, and we would then engage in some form of stewardship. So what we did would usually be circled down here with the plus or minus. So if we asked for IV to PO substitution, we would circle it, put a plus and a minus by it, and then essentially we would move on. The last is if we did have any notes to leave, if they were here for pneumonia, we would write in here whether or not we were compliant with the CAP protocol. One thing I just want to mention too is after the 48 or 72 hour timeout in this form, and we did our intervention, regardless if the patient was stayed at TMH or they were discharged, this form would be filed away and we stopped tracking the patient. So I joined Taylorville in 2017, and this was still our process. And so you might be asking, how did we intervene with just one pharmacist and doctors not sure when they were coming and going? We would go to the chart and we would leave Post-it notes. That was our intervention. What was really fun was, when you had a patient that you had intervened on and you saw the orders coming through for that day and your intervention wasn't accepted, and you'd kind of ask, well, why wasn't it accepted? So you'd have to go looking through charts. We didn't usually page the doctor. If we thought it was a really great one we might have or something that would cause harm, we obviously would reach out. But it really just created more confusion than what it was worth. So to get into tracking of days of therapy, this right here is a snip of a template that we would create. So only a couple people are familiar with CPSI. It does not calculate days of therapy to put out there for NHSN. So what we would have to do is we would go through each and every medication in a drug class. We'd have to type in that 7-digit item number that was associated with it, run an ad hoc, and then we would get paper that would print out. And then we would manually go through there and document how many days of therapy they were on vancomycin. All our patients for the month of June were on vancomycin. And we would do this for every drug class. We then took those numbers and put them into this Excel spreadsheet, which would give us a total antibiotic days. So the first part of just having to print all that out manually, because we couldn't figure out the system didn't allow us to just have a reproducible report run every month. We had to manually do that every month. That took usually about 3 to 4 hours. Filling out this spreadsheet usually took about a couple more hours. Um, the original, so one couple things I want to point out is that we did not originally look at individual drugs. We looked at drug category. For the redundant process that I just explained to do each and every IV medication, it was just going to take too much time. And originally, we tracked and we were trying to trend antibiotic days per patient day. For those of you that do report to NHSN or are currently tracking days of therapy, we usually see this in uh, antibiotic days per 1,000 patient days. That's essentially the same number. You just multiply it by 1,000. But when you're only looking, this was the only tracking metric that we were monitoring. We might have had great successes in fluoroquinolone usage, and we would have never known because we were using something else. And so it just wasn't a real productive use of our time. After we got that done, we then went back to those antibiotic forms that I talked about from our clipboard, and we'd bring them back out and we would look at how did our CAP compliance do and our HCAP compliance. We'd manually go through there and update them. We would look at, everything that we had in there, renal dose adjustments, de-escalation events. My favorite was IV to POs that were accepted. And why I loved those so much was you had the pleasure of going back into that patient account. So if you DC'd IV Levaquin, you would go back into that patient account, find out what day the IV Levaquin was stopped, then have to go count how many days of oral Levaquin was given, and that would calculate how many days saved we had. So the most we had in this calendar year was 17, but to do that 17 times took a lot of time. Over time, we were able to create some bar charts that showed, how often we were adjusting antibiotics, the timeouts that we were doing, and the days saved. Problem with tracking this stuff was it really wasn't actionable, right? I mean, you were kind of looking over time what we were doing, but we wouldn't know if something was out of compliance with our process, if a doctor was prescribing inappropriately. Nothing that we were tracking would help us lead to, better use of our time. So in March of 2020, antibiotic stewardship had a big opportunity at TMH. So we went from a 5-floor, 125-bed hospital, and we moved over to a 2-floor, 25-bed hospital. About 90% of our departments went to work on Tuesday, and when they came over on Wednesday, they were working in a brand new space with brand new equipment, a, a new door that they've never walked in to go to work for. I'm just curious, has anybody ever been a part of a hospital move like that? One? Okay. It was a great exercise in processes. We did a ton of process maps, how do patients get from point A to point B. It was a great experience to go through. I hope I never have to do it again. The second thing that happened is on Memorial Health, I found that the first time that we had any restrictions start was on Friday. So brand new hospital, never worked in that department before on Wednesday, and on Friday, COVID restrictions started. I don't have to tell you what happened after Friday 13th. So I apologize for this. I sent this incorrectly. It was just words though, so I can speak to them. So what I asked was, why did a new hospital and COVID equal a huge opportunity for pharmacy? So I mentioned there were a lot of workflow processes that changed, and our physicians required some help. And it was decided by leadership pre-hospital move that pharmacy would be the ones that would be essentially rounding with them uh, and helping them. So that was issue number one, is we were going to get rid of the post-it notes. We were going to have time to have one-on-one with them. The second was that during COVID, our hospitalists, we only had, or our primary care physicians, we only had 3 that saw patients. They got together and said, maybe it's not a good idea for all of us to come over, get in this small little room and try to fight over 2 computers and document on our patients. Let's just have one physician come on a weekly basis, and we'll do 1 week on and 2 weeks off. So we went from no pharmacists really having one-on-one interventions with our doctors to it to the pharmacists being with the doctors, essentially rounding with them. It wasn't quite rounds, but close enough. With this increased workload in pharmacy, leadership went ahead and increased our FTEs from a 2.0 FTE pharmacy to a 3.0 FTE pharmacy. And what I have shown here is an SPC chart of our IV only days of therapy. So in the first section, that was old hospital pre-COVID, our days of therapy, and then in the second is post or in April of 20 all the way to today. There definitely seems to be a change in the amount of IV antibiotics that have been administered at TMH. So further commitment that leadership showed was by purchasing clinical support software. That came in May of 2021. This was actually a system initiative with infection prevention requesting it. They do a lot of surveillance and a lot of submitting their own data to the CDC. So we were able to leverage, pharmacy and infection prevention were able to pick one together that would fit both of our needs. And we were able to get rid of the clipboard and the forms, and we started using Theradoc as our primary surveillance for antibiotic stewardship. So this is what our queue would look like. I don't know if I apologize if it's hard to see, but our pharmacists are able to go in here on a day-to-day basis, and they're able to look at what alerts are being fired for antibiotic stewardship. So the great thing about the software compared to the paper process was that this was going to track our patients for the entirety of their stay, right? We weren't putting it in a file and moving on. We actually could still get data, 5 days, 10 days down the road, and we would be able to make real-time interventions. We spent a lot of time in the pharmacy department picking the right alerts, what works for us. The first thing we wanted to do, Theradoc kind of has some stuff out of the box that you can use, but it didn't fit all the things that we were currently doing. So that was really priority number one is what are we doing right now that's working or that we feel is working, and how can we build it into Theradoc? And then just one other thing I'll mention about Theradoc and the alerts, we also built a anticoagulation and opioid stewardship and just a general medication management all when we rolled this out. So it wasn't just an antibiotic stewardship program that we started using. So this is several of our Theradoc alerts that we use. There's 14 of them or so up there. We have over 70 currently built that could fire on a day-to-day basis. I'm just going to mention about a couple of them. The two big ones were lab that always really irritated me is, our aminoglycoside drug levels and our vancomycin. We weren't always notified that a level had came back. So if you weren't aware to be looking for one, you wouldn't, it might get missed for a day or two. And then at that point, we were still using, well, I think previous to that, we had actually gone to area under the curve dosing. But regardless, you had an opportunity to intervene and you wouldn't be able to. We also did not know, a lot of times, even if a blood culture was ordered, and when Theradoc, when we implemented it, we knew when our blood cultures came back negative or positive. So once again, able to deal with that in real time was huge. I'm going to real quickly go back to this is my last polling question for the day. What are some antibiotic stewardship interventions that you use at your institution? Ideally, maybe one that wasn't listed. We got one. There's two. Yeah, bug drug mismatch. That was probably a better way to write it. That was our TAM report. I should have wrote that a different way. Ooh, max days of therapy, that would be a good one. I'm already thinking about how we can maybe build that one in Theradoc. Uh, appropriate antibiotic susceptibility, that would be interesting. Yeah, there's some great opportunities even for me too, so I'll make sure to save those and see which ones we can maybe implement at TMH. I appreciate the feedback. Yeah. So we were able, so one of the great things about Theradoc is it immediately gives you days of therapy. The only problem with it out of the box is Theradoc gives you all the data and it's almost overwhelming. If you try to look at everything, you feel like you're trying to boil the ocean. So something that we did very early on is we said we need to really look at some specific things and what's going to be most important here at TMH. So we decided to look at the top 5 drugs that were used at TMH on a monthly basis. And what we saw was consistently ceftriaxone was number 1, probably not surprisingly, but it never really seemed to go all that high up or down. The image on the right is an SPC chart for TMH, and it looks like pretty consistent usage over the last 3 fiscal years. So that's actually a quality initiative that we're trying to look at now. Is there opportunity with our ceftriaxone usage, and can we possibly use a little less? I added this slide just as a kind of a tip. I really enjoy. I heard this once that anytime you have some kind of big change, right? A physician group change, a hospital move, new software that you start using to try to alert yourself of when those things happen. And what you have here is pre-COVID, pre-hospital in the first, and the second is that's when we started making our one-on-one interventions, and the third is when we got Theradoc. So it's a little hard to say that from gaining Theradoc that we've seen a real decrease in IV therapy, but for sure the one-on-one and adding Theradoc has definitely made great strides here at TMH. So now that we had all this time, right? I wasn't printing reports, I wasn't sitting there manually going through the days of therapy. I had more time. So we started looking at what are some opportunities that we have. We started looking at organisms. We picked out 3 specifically, and we decided to start tracking them over the amount of time that we had. So this is E. coli, and something I was really proud of this last year is how much our ciprofloxacin and our trimethylsulfa have consistently gone up. If we continue to see a trend like this, maybe we can add them into empiric therapy, or maybe we might decide that, you know what, it was just back in 2018, we were only at 70%. Maybe that's not a great idea, but this was stuff that we would have never had before had we not started looking at it. Protocol compliance. There was a point in time where TMH fell out of compliance with tracking our protocols. With Theradoc, we were able to find a way to get back and to be compliant with that. And so that's something that we're tracking now. We started performing more presentations. We did a review of the CDC antimicrobial resistance presentation, and then CAP and C. diff guideline updates. We used a QI project where we looked at vancomycin. So I think I mentioned we used DoseMeRx for area under the curve dosing. We realized very early on using their analytics tool that we weren't successful at getting patients to therapeutic levels in the first 48 hours. I think the first time that we looked at it, we were only at like 25% in the first 24 and only 65% by the first 48 hours. So we went back, we did some re-education, we reset, what our expectations were. And in the next quarter, we went to like 80% in the first 24 hours and 95% in the first 48. But once again, if you're not tracking this type of stuff, if you're not looking at it, you can't fix it. Monitoring days of therapy. We currently, on a monthly basis, I update 4 specific drugs. And then we also look at our IV therapy because that's what we have the longest historical usage of, and then also our total antibiotic therapy. And we're just looking for large, dips, or if there's anything that seems to maybe process has changed, administration habits have changed. We track our interventions at Taylorville. So through Theradoc, right on that screen, you're able to add your intervention. Was it accepted? Was it denied? And I go through those on a monthly basis, and I'm trying to look for usually about 50 to 100 interventions. That's about where our baseline is. And I try to look for an acceptance rate of 80 to 90%. And that's about as far as I go. When I was manager, we had essentially 100% turnover in our staff pharmacists. And almost immediately, when we had both new pharmacists working, we saw a dip in that. Well, it wasn't because we weren't doing the stewardship activities. We just weren't diligent in doing the documentation. But I'm sure, as we've all heard, if you don't document it, it didn't happen, right? So we made sure to get them back into compliance with that. And we actually were a lot higher in our total interventions than when I was at TMH. Something that I just haven't, dove into is we're constantly our IV to PO, our de-escalation events. Those are always the lowest percentage of acceptance. The great thing with Theradoc is you can click into those and really get those individual and any notes that your pharmacy team leaves. You could analyze those. We haven't made that a priority yet. And then finally, policy creation. So in 2023, Joint Commission had updated some of their elements of performance, and we did a gap analysis, and we found that we really weren't, that pre-authorization was something that we were missing. So we created a formulary restriction policy that helped us gain compliance with that Joint Commission requirement. So hopefully it's been pretty clear. If you don't measure something, then you can't fix it, and you should really let your data guide your QI projects. And probably just as important to that is when you're designing what you're wanting to look at, try to think, is this something, if we get numbers and whatever they are, well, one is, can we measure this? And then two, once we get those results, is it actionable? Is a dip gonna say that we need to work on something? Because if it isn't, is it really worth taking the time to track those things? I've had a Joint Commission come and interview us since the 2023 new elements of performance. They will ask you about what you're monitoring, and they will ask you why you chose to monitor that. So I think thinking about the things that you're looking at in your stewardship program is important. And then probably one of the most important things I think is really sharing with your physician team that's on, just not your stewardship physician team, but the physicians that work in your hospital, really sharing with them your successes, where you see some opportunities, and asking them for their feedback to try to gain some buy-in. And then finally, sharing it with the C-suite and with leadership. And it was stated earlier, really share with them where you still see opportunities, because they, hopefully, if they are constantly seeing all the great things you're doing, then they might be more willing to give it to you, versus the only time they ever see is when you're complaining and telling them about things that you do need to be successful. Just give me 1 second. All right. So I mentioned the Joint Commission, new elements of performance, and I had mentioned earlier that we had fell out of compliance with the pneumonia protocol. We knew through the gap analysis this was something that we needed to track again. So we, prior to starting the tracking of it, we didn't just jump in and say, we got to do it, let's figure out a process. We took a step back and we said, one, is this really the right protocol? We have SSTI protocols, we have UTI protocols. Is this the right one to focus on? And we felt it was, just because of the sheer number. And if we did make any changes in the process, that we would know if they worked or if they didn't. The second was, all right, we're going to track compliance. Is there anything else we should look at? My team came back and they said, we think we're going to be pretty good on the compliance with the protocol, but we're treating way too long with days of therapy. So the first problem that we had to solve was, how are we going to track this, right? We used to do it On paper, the pharmacist would fill it out. We had gotten rid of that. We're using Theradoc. We do have our protocols built into the electronic health record. Unfortunately, our physicians don't really use those, so that wasn't going to be a good way to know if they were compliant with the protocol or not. So we went to Theradoc and said, how can we build something? And they helped us build two things. One, on every new pneumonia admit, they were able to build an alert for our pharmacy staff to actually see that. So the pharmacist could actually intervene essentially on day zero, right? We're not on the right dose of, Levaquin or levofloxacin, or, we don't have atypicals covered here. Can we get it added? The second was at the end of the month, we're able to go back in and it gives us a queue of all of our pneumonia admits. After we went through our data, we found that we had 82 compliance with the pneumonia protocol, which we thought was pretty good. I mean, why spend time working on that? A 10% improvement, you're going to get up to 8 to 90%. Is it really worth the work? But we looked at the median days of therapy for pneumonia, and that was 9 days. So that was what they got IV and PO in the hospital plus what we discharged them on. That was 9 days. So we took this information back to our stewardship team and we presented this data to them. And then we reminded them that the American Thoracic Society and the Infectious Disease Society of America recommends 5 days as appropriate therapy if patients are improving. Um, and uh, and we weren't saying all patients need to be given 5 days. We were just asking our physicians, can we move that goal line? We had physicians, what day of therapy are they on? Okay, well, we're going to treat them with 10 days. And it just seemed to be a common theme. They always wanted to treat with 10 days. So all we were doing was just asking them, can we move that goal line from 10 days back to 5 days? The next quarter, when we came back, we saw a 32% improvement in the mean of treatment days, and our median dropped from 9 to 6. So we all celebrated. We made sure to share this with our stewardship leadership. We shared it with the hospital leadership, and I made sure to file this into our antibiotic stewardship and QI folders for Joint Commission. So moving on to some references, the Sanford Guide and the Hopkins Electronic Reference, both are great for disease states to individual drugs. They're very cheap. We provide both of these to our pharmacy staff. It's $65 annually for your staff. Some websites that I've used in the past that I think are really great resources, SIDP, Society of Infectious Disease Pharmacists. I used their vancomycin area under the curve toolkit. This was a phenomenal resource when we needed to train. They have it for the pharmacists, they have it for leadership, for nurses, and I basically took all their stuff and put TMH all over it and then presented it. It was a phenomenal product that they put out there. They also have an education center with continuing ed, and they have a podcast, usually comes out about once a month. So if you enjoy listening to podcasts, I think you would, and you're into antibiotic stewardship, I think you would enjoy those. ID stewardship, I don't use this one as much, but it's great to learn about infectious diseases and antibiotics. And then Northwestern Medicine and the University of Nebraska, both, I think I heard University of Minnesota, I've been on that one as well. They have great guidelines and protocols, antibiotic dosing materials, and just great articles to follow up on. So some takeaways, start with the low-hanging fruit, right? Choose something that you're going to see often and that you should be able to easily implement. Renal dose adjustment policies with antibiotics, they're important and they should be really easy to add. I never have gone to a physician and told them, with the patient's creatinine clearance that we should be using a different dose and never been told no. IV to PO policy changes. We don't have an auto sub, but we do have a policy that helps our pharmacists pick the right PO agents with the IVs. And then durations of therapy. I think the university, I forget which, actually the CDC has, there's several resources. CDC has, the 5 days for pneumonia. when you're building out your UTI protocols, making sure that you're putting, for cystitis and treating with the fluoroquinolone, this is the preferred days of therapy. These are in the guidelines, so make sure to have those when you're making your antibiotic recommendations. Low resources can still have meaningful impact or interventions. If you looked at, I don't know if it was easy to see or not, but on that Excel spreadsheet, like we were still getting stuff accomplished with our Post-it notes. Now, obviously, we've improved since then, and obviously having a face-to-face is more meaningful, but it does still work. And then if I would go back and talk to myself in 2017 with that monitoring form, I would just say, just go ahead and keep that piece of paper until the patient's gone. Not gone, but discharged from the hospital. And then finally, with our clinical support software, we hopefully all are submitting data to NHSN for patient or for antibiotic use and antibiotic resistance. That's a great way to sell it. Work with your infection prevention team, see if they would want it, see if you can have both departments going in to see if leadership would be willing to purchase it for you. Not underestimating the value of relationships. Face-to-face communication is so important. We've had another process change at Taylorville in November. We went from our 3 primary care physicians that saw all the patients, and we've moved to a hospitalist setting. So now we have up to 11 hospitalists on a 1-week rotation, and it's split down the middle. Half of them love doing rounds with us, and the other half, they want you to halo message them, right? Secure messaging. And that's been a real struggle for us. We're still working through that, not having physicians that want us to round with them. So we're still trying to figure out how we can, make those relationships meaningful. When you go to a doctor to make recommendations, share what day of therapy we're currently on. If you're going to recommend a dose change or a drug change, have the dose and the frequency ready to go, and then know how many days is recommended to continue therapy for. Something I need to do a better job is recognizing positive work that we're doing, whether it's within your own department or with your stewardship team or with leadership, and setting up a cadence to report to leadership. You are supposed to report at least annually. And if that fits the needs of your facility, I think that's fine. But, talking and keeping this topic in front of leaders is always a good idea. Leverage other disciplines. I'm going to talk about that on the next slide, so I'll leave it there. And then be respectfully persistent. Anybody that's done antibiotic stewardship for longer than an hour has been told no, right? We get told no a lot, and that's okay. But, don't let that get you discouraged. Try again the next day. Try to listen. I thought that interaction I thought was fascinating when we were talking about asymptomatic bacteria with the 2, I think it was, IP nurses, and then the physician that got up there. And I really hope they really heard what he was saying. I mean, it's there might be other things out here other than, yeah, I understand she's confused, and that's not a reason to treat someone, but really listening to the rationale of the physicians is so important. And I just thought that was a really interesting interaction. So talked about leveraging different departments. So when I got to Taylorville, it was only the pharmacist manager talking to leadership about antibiotic stewardship. We've been able to include microbiology in our stewardship activities. We help them choose new gram-negative cards for when they're going to be switching. We added meropenem to our formulary and removed imipenem. Unfortunately, when we did that, we didn't have cards that gave susceptibility for meropenem. So we worked with Micro to get that changed in a pretty quick, before we actually made this change, and it was within like 2 weeks we were able to accomplish this. So it was a delayed sensitivity, but we got it still within 24 hours. Infection prevention, I've already mentioned. We were able to work with them to bring on Theradoc, and they've presented on unique patients that we've had in the past couple of years, and then also unique organisms in our stewardship meetings. Nursing department. I really do believe those are the sleeping giants for an antibiotic stewardship program. They see our patients on a day-to-day basis. I think their ability possibly to de-identify allergy or penicillin allergies is huge. You know, I was wondering too, somewhat. I mean, this is just anecdotal, and this is my experience. I mean, I still will walk around on the floor and hear nurses talking about how they've been recommending a UA because they can smell the infection. You know, we've tried to provide that education that that's not a reason, you know, to perform a UA. But I think there's so much opportunity if we can, you know, guide them and give them the right education that they could be huge champions of the stewardship program. And then finally, for the pharmacy team, we write it in our job description that you're going to be taking part in antibiotic stewardship. There's only 3 of us, so you know we got to do it. We provide SIDP certification. We try to get everybody enrolled within the first year of employment. And then finally, Taylorville is definitely lucky in having system support. I understand not everybody has that, but I think the first presenter gave us a goal. Was it to meet 2 new people or 3 new people? I've never met a pharmacist that if you know, become friendly with them, that if you call and ask them for help, that they're not going to give you, you know, even if they're in a different health system. So I think even if you can't find support within your own system, reach out to some friends, and I can guarantee you're going to get good feedback from them. So for my final slide, just has some conclusions. Write down your stewardship goals, and try to limit it to 3 or less. I believe that when you have more than 3, you don't have 1. So write them down. Have someone keep you accountable for your goals, and put a time range on your goals. Don't let them sit out there and let them be out there indefinitely. Monitor things that matter to you and to your department. You know, what I presented today may not be an issue at your facility, and that's okay. But you know, try to find things that do matter. Put time on your work calendar for stewardship activities. When I first started as manager, it was every Wednesday from 10 to 11. That was my stewardship time. I would occasionally close the door. Sometimes I would leave just because the pharmacy was crazy and we had a pharmacist to take care of it. But if you don't plan your time, someone else will plan it for you. And then finally, I'm just going to end with a quote and a book recommendation. If you like process improvement, which is changes that seem small and unimportant at first will compound into remarkable results if you're willing to stick with them for years. And that was by James Cleary, the author of Atomic Habits. So with that, I'm happy to answer any questions that you may have. Yep.
I'm finding similar purple aspects we and finding this off. We do have something called right, but how I guess what I'm open to it, how do you find the time to read farms, there's small farms and we don't have to check. And sometimes there's check off if you're there.
Yeah. So obviously, you know, I can't tell from that 3.0 FTE. Do you have 2 pharmacists there during the day, or?
We also so third farm.
Yeah. So I'll just speak to our process and how we do it. So Monday through Friday, we're going to have 2 pharmacists there from 7 to 3:30. So as manager, I stay in the pharmacy and my staff pharmacist. So right now, current process is we have a utilization review meeting that pharmacist is responsible to be at 8:45. So I know every day he's going to be gone from 8:45 till probably approximately 9:15. And then, you know, so now that we've moved to this new hospitalist model, sometimes our doctors show up at 9, sometimes they show up at 1. So we don't know when the doctors are going to be there, but we do we will, I mean, basically the expectation is when they show up, you go upstairs. And you're going to round with them with, like I said, about half of them. That's what they expect and that's what they want. Um, and then on days if, someone has to cut out and the rounds we know are going to be a couple hours, we don't round with them. We still have our interventions. We use Halo, so we use secure messaging. We'll make those, antibiotic stewardship amongst other interventions, and we just message them and then follow up with from there. But um, we just try to make it a priority. We realize it's just not antibiotic stewardship. I mean, we do a lot of other things. We do anticoagulation. We do second med red checks. We help with discharge orders. We help with admission home meds. So we have a lot on our plates, and we we try to make a way to make it work. But yes, I understand what you're asking. We have the ED is usually pretty busy, and then surgery can be very busy, and you have to be available. So it is a challenge. And on days like that, if the doctor was there and I knew my pharmacist was gone, I would not shut the door, even though it was on my Outlook calendar. That calendar was more for other meetings that others might try to schedule with me. I know that I'm going to be in the pharmacy able to work on it. And if my pharmacist is in there, well, then maybe I can shut the door and have one uninterrupted hour of work. But now that our program has been rolling and we have the system support, that was something that was new in 21 or 22. I actually only have a 1 hour block the whole month. And that's when I do my MHSN reporting. And then a lot of those days of therapy, that's when I go through and track that. I track our interventions, and I'm just looking for things that may be out of compliance. Yes, sir.
Those interventions, either by monetary value, or things that hospital stay with computers. What is sort of I am running to is frame the patient that there's exercising the patient on so you get new progress developed. This is so what I'm doing is actually back to
Yeah.
Right.
So I don't have a way to quantify it for days, days saved or from that point of view, but Theradoc does have a lot of evidence-based interventions that have dollar amounts connected with them. And we've never used them just because I think like the first month that we did it, we saved the hospital $200,000 or something. It just seemed, I mean, we were doing a lot of stuff and we were intervening on a lot. I mean, if you look there, we had over 1,000 interventions over the course of a year. And that was just for antibiotic stewardship. That wasn't our anticoagulation and our general medication management system either. So to answer you, yes, Theradoc has it pre-built, and they actually have evidence to support those dollar amounts. Sir.
You had mentioned if you don't track data, parts of kind of thing, not something really track the item level that you're tracking. What prompted you to track that specifically, or is something kind of the same thing that
So when we got we switched so we were trough-based dosing prior to dose me. We weren't doing the manual calculations for area under the curve. So when we moved over from trough to air to from trough-based dosing to area under the curve dosing, we knew that we needed to have some kind of mechanism to know, are we causing more acute kidney injuries, or are we treating these patients appropriately? Are we getting them to therapeutic levels quickly enough? And so we were already doing, so what made us do it? We felt like it was important, right? We're using this new way of dosing. Is it being beneficial, or are we causing harm? We needed something to track. So we actually were looking at, now we did it was homegrown, it was our own. And we just looked at, did we get the patient to a therapeutic level? And then we would put it with what the trough was. And that was kind of our QA at the time. And then we also looked for acute kidney injuries. And we had done so we did trough-based dosing. I think we had a sample of like 30 patients. And we looked at how many of those patients did we think got to therapeutic based on our protocol at the time, and then how many developed acute kidney injuries. So we kind of had some pre and post. We told Dosing RX from the very beginning, I think others had told them as well, you need some kind of, QA built in, and they said, oh yeah, we'll give you QA. So that very first report we got, it was something that their team had to work on, and it came in a PDF, and you could not change. So if we had questions, we're like, well, why'd you do it this way? We want it to, we want to see it over a course of a month, not over the course of a week, because at TMH, we may only have 1 or 2 patients. So if we didn't have a patient get to therapeutic level, then it was 0%. Well, can we maybe make that time frame a little bigger? So my point, or what I'm trying to say is, from the very beginning, we knew that it was going to be important for us to look at that. And then over time, DoseMe now has an analytics section. It's just, you want to go dose a patient, you hit here. If you want to look at the analytics, you hit here, and you can go in there and you can change all those settings from, am I looking at per day, per week, per month, per year? And so they've really improved their platform to give you that real-time data back. I do think it maybe is like a month behind, but it's pretty good. So I think it was just, once again, it was something that we felt was a priority, and we felt like, getting a pre and post sample would be a sufficient way of looking at that data. The data that I shared, we weren't looking at the first 24 to 48 hours. DoseMe sent us that, and we were kind of like, well, why are you looking at that? And so they sent us a study that we just weren't aware of, that talked about getting patients to those therapeutic levels quicker was, had better results, which makes sense. But it just wasn't something that we really focused on. We just wanted, because I'm sure most people here probably get that if you're still using trough-based dosing, either for the 3rd or 4th dose. So that's kind of when we were looking at it, is let's just get them to therapeutic levels by the 3rd or 4th dose. But then we recognized that there was an opportunity to, improve it within the first 24 to 48. Okay. If you want to use my slides, what I had sent them like a month ago was different than what was presented today. So if you do want to use these slides, or if there was anything in there that you were interested about, I'm happy to give you my email address and send them. So I just wanted to mention that if you use the little drive that they gave you, the slides are dated. So thank you, everyone.